Today, we're jumping into a real heavyweight in the antibiotic world, Linezolid. We're going to do a clinical deep dive into this drug because while it's an incredible tool against some nasty superbugs, its power demands a whole lot of respect. So let's get right to it. You know, this statement really hits the nail on the head. It perfectly sums up the two sides of the Linezolid coin. On one hand, it's a critical weapon against infections that laugh at other antibiotics. On the other, you absolutely have to know what you're doing and watch your patient like a hawk. So here's our roadmap. We'll start with why Linezolid is considered such a critical agent. Then we'll get into the nitty-gritty of indications and dosing. After that, we hit the big one, its safety profile, which requires constant vigilance. We'll wrap up with interactions and resistance, and then a quick knowledge check to lock in the key points. All right, Section 1, a critical agent. Understanding Linezolid's place in therapy. You have to ask, where did this drug come from? Well, it wasn't just pulled out of thin air. It was born out of pure necessity, a direct answer to a growing crisis in infectious disease. So what is Linezolid, fundamentally? Well, it's a synthetic antibiotic, part of a pretty unique family called the oxazolidinones. Now, here's the key. Its job is to stop bacteria from making more of themselves. It literally hits the brakes on their protein synthesis. We call that a bacteriostatic effect. And because its mechanism is so different from our older antibiotics, it's a total game changer against bugs that have already figured out how to dodge everything else we can throw at them. Okay, on to indications and dosing. So when and how do we actually deploy this thing? Getting this right is fundamental to good antimicrobial stewardship. Let's put Linezolid head-to-head with an old workhorse, vancomycin. Right away, you can see where it shines. Yeah, sure, both can handle MRSA. But look at VRE, vancomycin-resistant enterococci. For VRE, vancomycin is out of the game, but Linezolid is effective. That's huge. And then there's the other major advantage, a purely practical one. Its oral availability is fantastic, while Vancs is poor. This makes it so much easier to treat patients outside the hospital. So that brings us to its key uses. You've got your MRSA and your VRE, obviously. But it's also a powerhouse for complicated skin and soft tissue infections. And think about those really tough, long-term cases, like a fracture-related infection or suppressive therapy for chronic osteomyelitis, where you can't just take the hardware out. Having a powerful oral option here is just invaluable. It's also great for things like CAPD peritonitis, where you can easily switch from IV to oral. Let's walk through a case to see how this plays out. Imagine a patient with an infected joint prosthesis, and the bug is enterococcus faecium. What are your oral options? Suddenly, linezolid might be the only good choice you have. Now, this is an off-label use, which means you're stepping it into a clinical gray area. And in those moments, sitting down and having a really frank discussion with the patient about the risks versus the benefits, that's not just checking a box, that is essential medicine. You know, one of the things clinicians just love about Linezolid is how beautifully simple the dosing is. It's 600 milligrams twice a day. End of story. And because its oral bioavailability is nearly 100%, that dose is exactly the same whether you give it through an IV or as a pill. That makes switching from inpatient to outpatient care incredibly seamless. Okay, we've arrived at arguably the most important section of this whole discussion, the Vigilant safety profile. Because for all its incredible power, Linezolid comes with a very real potential for serious trouble, and it demands our full attention. I really just want to let this sink in for a second. Vigilance is non-negotiable. That's it. That's the core message. You simply cannot separate the benefits of this drug from the duty to monitor the patient. It's not an add-on or a nice-to-have. It is a fundamental part of the therapy itself. And here is exactly why that vigilance is so critical. We're not talking about minor issues here. We're talking about severe, sometimes irreversible complications. Myelosuppression, that's your bone marrow getting suppressed, especially low platelets, is really common with long-term use. You can get peripheral and even optic neuropathy, nerve damage, that might not go away. And then you have the acute, life-threatening metabolic crises, lactic acidosis and the famous Serotonin Syndrome. So, what does this vigilant monitoring actually look like? Here's the playbook. Before you even start the first dose, you need a baseline complete blood count and liver enzymes. Then, during therapy, that CBC needs to be repeated every single week. No excuses, that's how you catch myelosuppression early. And you have to always maintain a high index of suspicion, ready to check things like creatine kinase or for signs of acidosis, if anything feels even a little bit off. All right, now that we have a healthy respect for its safety profile, let's move into some of the more advanced considerations. We're talking interactions, resistance, and switching. The key to understanding its drug interactions comes down to this. Linezolid is a weak, reversible, non-selective monoamine oxidase inhibitor, or MAOI. That specific property is what creates the risk for serotonin syndrome when it's given with other serotonergic drugs, like SSRIs. This is why a thorough medication review isn't just a good idea, it is mandatory before starting therapy. When you're using a last resort drug like this, you have to be precise about what susceptible actually means. The answer is in the MIC, the minimum inhibitory concentration. And as you can see here, the breakpoints, the numbers that define resistance, are different for different bugs. For E. faecium, an MIC over 4 means it's resistant. For staph, you want that number to be 2 or less. These aren't abstract lab values. They are the definitive guide to whether the drug is actually going to work. Let's circle back to that IV to oral switch because it's such a great feature. For serious infection, a typical protocol is to hit it hard with IV linezolid for a week or two to get it under control. Once you see clear, undeniable clinical improvement, you can confidently switch that patient to the exact same dose in a pill. Think of the benefits. Patients get home sooner, fewer IV line complications, lower costs. It's just a huge win all around. A quick but really important note on special populations. What about using linezolid during pregnancy, in kids, or during lactation? The short, honest answer is we just don't have good safety data. And in medicine, an absence of data means you proceed with extreme caution. The threshold for using it in these cases has to be incredibly high, and it's absolutely a situation where you should be getting an expert consultation. All right, let's wrap this up with a quick knowledge check. Time to test your understanding of the most critical concepts we've covered. First question, focusing right on its clinical sweet spot. What are the two big resistant bugs where linezolid is a go-to weapon? And the answer, of course, is MRSA and VRE. Its activity against vancomycin-resistant enterococci, in particular, is what really made it such a landmark drug when it first came out. Okay, next one, hitting on that crucial safety point. Because of its MAO inhibitor properties, what's the big, dangerous syndrome that's a major risk? That would be serotonin syndrome. And this is a vital takeaway. You must review a patient's entire medication list for any interacting drugs before starting linezolid to avoid this potentially fatal complication. And so I'll leave you with this final thought to reflect on. We have this uniquely powerful tool, but it also carries these significant risks. So the question for us as a clinical community is, how do we protect it? How do we ensure linezolid remains the precious last line of defense we need it to be and doesn't just slide into becoming a first-line convenience? Thank you for joining me for this explainer.